Now again with Dr. Majid, we will have presentation about assessment response of the nasopharyngeal cancer and treatment complications.
Okay, so earlier we talked about the nasopharynx tumor. Now we are going to talk about the post-treatment neck imaging after the nasopharynx has been treated. So always trainees and some early budding, even neuroradiologists, panic when it comes to post-treatment neck. So whenever you have to read a post-treatment neck scan, be prepared. Review the medical record in advance of the imaging review. You have to know where the primary is, what treatment has the patient received thus far. And very important to note is check the pathology, whether the margins of the pathology were positive or negative. That's very helpful when you are evaluating a post-treatment scan. What is the reason for the scan? Is this a routine follow-up, or is the patient coming in with a new symptom? And then always make sure that you compare to multiple prior exams if they are available, rather than compare only to the most immediate prior study that you have. So why do we image in the post-treatment setting? One is that we want to look for any complication that is related to the disease itself or the treatment that has been instituted for that disease. Or, of course, we are looking for tumor recurrence. And more often than not, it will be the radiologist that will be picking up the tumor recurrence in a post-treatment neck scan. So as we CT PET is very useful in the post-treatment neck setting, as we already alluded to earlier on. But you cannot do this scan within the first 12 weeks because of the inflammation, edema, and distortion that will give you positive signs without any evidence of positive disease in there. CT is very good. MRI can be utilized, especially these days with diffusion-weighted images, or MR-CT complement each other also very nicely in this setting. So before we venture into our imaging part, what are the treatments that are being instituted for nasopharyngeal carcinoma? So radiation is the mainstay of treatment for nasopharyngeal carcinoma. Surgery is not offered for nasopharyngeal carcinoma because where it is located, all the vital structures are there. The real estate is too high and too big for surgeons to go in at that level. Chemotherapy for local regional recurrences, or if there is metastatic disease. And now immunotherapy, IO, and all other new fancy treatments are being given for this. So how do we follow our nasopharyngeal carcinoma patients as and when they are treated? So at our shop, we usually do 2 to 3 months follow-up for the first 3 years, and then less frequently depending upon what we are seeing. Follow-up is usually continued up to about 7 to 8 years because of the risk of the late recurrence that can happen in some patients. And usually, almost always, the patient will get clinical exam and an endoscopy. Earlier on, you will be CT or MRI will be done, and then after 3 years, as and when needed basis for imaging. So endoscopy versus imaging. It's very sensitive, we know, but it's sensitive for mucosal disease. And if there's a mucosal recurrence, they will easily pick it up. But remember that the patient has had radiation. So you will have radiation-induced mucositis, and you can have trismus, in which they can't even open their mouth. So it's not possible to do a good clinical exam in such a setting. If the tumor or the recurrence is submucosal, then they will not see it. So it's us that has to see that on imaging and let them know about it. And so that's the reason that imaging also is being included in the routine follow-up of these patients, at least early on after their treatment has been instituted. So what are the general changes that we see on our scans? Obviously, skin thickening, subcutaneous stranding, mucosal edema is seen throughout the neck in the treated areas. We see involvement of the salivary glands. They are very sensitive to radiation, so you can have increased enhancement of the salivary glands, sialadenitis, and later on in the later stages of the disease, you can have atrophy of the gland itself. And then you can either have the muscular atrophy also develop because of the radiation therapy that has been instituted. So the two types of radiation that are given to these patients is either conventional, but now because of the advances in radiation therapy, it is mostly the image modulated radiation therapy that is given to these patients, specifically targeting the tumors. This is the radiation treatment map where they go with the gross tumor volume, the clinical tumor volume, and all that. So this was a very, very interesting study that was done from University of Wisconsin. So this was a nasopharyngeal cancer that was mapped by the radiation oncologist there. And then this image was sent to many radiation oncologists, both in private practice as well as in academia. And the question was, how would you treat this nasopharyngeal cancer? How would you plan to treat this nasopharyngeal cancer? And what they got was hundreds and thousands of different plans from many of these oncologists that were out there. And the main difference was between private practice radiation oncologists versus academic radiologists. So that we knew that treatment is different by different radiation oncologists. But what does that mean, especially for a nasopharyngeal carcinoma? So what they saw was that in US, there is no fellowship in radiation oncology. So they are residents, and then they become radiation oncologists. There's no dedicated fellowship. But in most of the academic centers, there are radiation oncologists who do more dedicated head and neck oncology, and hence they become de facto specialists in head and neck radiation oncologists. So for the patients who were treated by general radiologists out in radiation oncologists out in private practice, the survival at 5 years was 51%, as opposed to people who were treated with head and neck specialized radiation oncology in most academic centers was 65% were alive at 5 years. So that was a 18% survival difference between the two groups. So that is astonishing. So it's very important that you get treated at a place that do treat every cancer, but especially nasopharyngeal cancers, because as you can see, 18% survival difference there. So coming to the complications of the radiation therapy now, so you can have acute complication that happen early on, and then chronic complication. Most of the time, acute complication will be mucositis or skin reactions. Skin reactions can be infection, which again can be acute or chronic. The chronic ones that we see is xerostomia, very, very important, very, very common complication of radiation therapy. You have dental caries that develop in these patients. You have trismus, which can be quite bad at times. They cannot eat anything and have to survive on liquid diet. And then, of course, the other radiation-induced malignancies and osteoradionecrosis. So these are the complications that you can see in a patient who has been treated by radiation. So this is a journey of a patient with nasopharyngeal carcinoma. So this is, patient was treated, following CT, you can see some osteitis happening in the skull base. That's absolutely fine. Everything was normal. Again, CT was done at a different time point. PET was done in between just to make sure everything is fine, and everything was fine. Then patient started to suddenly complain of some dizziness and came back. imaging was done, and you can see that enhancement in the cerebellum. So this is radiation-induced necrosis. Our radiation oncologists hate that term. They want us to call radiation-induced injury. So obviously that has developed, which is okay, which can happen. This patient was about 5-6 years out by now. So that can happen, we know that. You can see ovale, there was some enhancement in ovale, but there was no symptom that the patient was complaining of. So we were just doing routine follow-up that everything is post-radiation change. Here you can see some enhancement has increased and going more laterally, which was fine. Then we reached to a point that we saw this large area of non-enhancement within the petrous apex right next to the jugular foramen, and we started to get a little incy that is there something happening, but it was non-enhancing, so we were still okay. But then the next follow-up scan, we saw trigeminal, that's enhancing. Patient was still not complaining of any symptoms related to the trigeminal nerve involvement. But finally, one of our last scans that we did, we saw that there was some restricted diffusion in the patient. So that was the time that we said, okay, we are not sure now. This definitely can be either a mixture of post-radiation change versus tumor inside it. So we'll have to go in. They went in, and you can see this multiple biopsies from multiple areas were taken, and all were negative for malignancy. Those were all post-radiation changes that had happened in this patient. So it can be a real spectrum of changes that you can see in such patients. This is another patient with nasopharyngeal carcinoma treated nicely, was doing well, and then suddenly developed some dizziness and some weakness on the right side. Of course, you see the lumen of the carotid artery is completely narrowed, followed it up. There's a intraluminal clot there, and you can see the lumen of the carotid artery on that side. Patient had developed these multiple embolic infarcts on that side. Patient was taken for clot retrieval, and you can see that very ragged-looking cervical internal carotid artery. So started to do the clot retrieval. The carotid closed on us completely. We kept on going, opened up the carotid, opened up the MCA, and we were very happy, but finally closed on us again. So this is radiation-induced vasculopathy. This is not a straight, simple clot that is in the carotid, and you can pull it out, and the carotid will be absolutely fine after that. So we're probably 2.5 hours in there, and the vessel did not open, and finally a decision was made to just sacrifice that carotid artery. And once we sacrificed it, then they became heroes, and they wanted to go in and do surgery. But again, you can see multiple biopsies were taken, and all of the biopsies came out negative for cancer in this patient also. So this gives you an idea about how bad some of these radiation changes can be, especially in the central skull base region. So we talked about mucosal thickening that happens, or mucositis that happens. So here is the nasopharyngeal cancer. This patient was treated, and you can see the enhancement of the mucosa up and down depending upon what was included in the field of the radiation therapy. So it's very common to see that. And really, this is a combination of edema, fibrosis, and telangiectasia that happens in the mucous membrane. Obviously, if they can see it also, this is mucositis that is seen readily and these are just some examples of what they see when they go in for their routine examination. I told you that salivary glands are very sensitive to radiation, so one of the clues early on is that you can see hyperenhancement of the gland. They can enhance bilaterally, they can enhance unilaterally. So post-radiation change, always if your glands are hyperenhancing, that's post-radiation change in the gland. Again, this is dermal thickening, subcutaneous edema, platysma is thickened on that side. This one is enhancing more than the other gland, so this is all post-radiation change, and sialadenitis in these patients. One of the things that happen and is a very important complication for post-treated neck patients with radiation is xerostomia, as I said. So that is practically that your salivary glands are not secreting saliva. And you can imagine a dry mouth all the time. So it's a very dreaded complication that unfortunately happens in many of these patients that have been treated with radiation. We at Hopkins have actually started a gene therapy to look into this, and the few patients that we have done, there has been some regeneration of saliva that can be produced in these patients with very bad xerostomies. So again, this is an enhancement of the gland itself, as you see. And you can also see some retropharyngeal edema also that this is skin change, obvious to them. They don't need us for this. So the other things that can happen in a radiation treated patient is that all these dental caries, they can happen, and then what we have to look for is development of these things: tissue necrosis or mucosal necrosis, osteoradionecrosis, vascular complication, and induction of secondary primary malignancies post-radiation. Dental caries, as I said, they usually take all the teeth out so that they can prevent development of this complication early on, and that's a routine now if you are going to radiate the patient, especially around the oral cavity and all. Trismus, extremely bad complication if it happens. Fortunately, the incidence of trismus is not very high. About 2 to 3% of patients post-radiation develop a really bad trismus like this, in which you cannot just even open your mouth more than 1.5 centimeter. Mucosal necrosis, this is not mucositis, this is actual big ulcer of the mucosa which is burrowing down and causing submucosal issues also. So what do we normally see is that there's lack of mucosal enhancement. You may or may not see ulceration. You can see some foci of gas in that area, and they can also pick it up on direct visualization, so that is mucosal necrosis. And this is a patient that was treated by radiation for nasopharyngeal cancer, and then you can see in the central skull base, now you have development of this hypoenhancement area that was actually a mucosal ulceration, and when they went in, they saw this necrotic tissue behind that ulcerated mucosa. This is not a nasopharyngeal carcinoma, this is actually a base of tongue cancer, but you can see again that there is this mucosal ulceration that is extending along the base of the tongue more anteriorly into the oral tongue also. So that's mucosal ulceration as a complication of radiation therapy. Osteoradionecrosis is one of the dreaded complications of radiation therapy, especially in the head and neck region. And usually it is because of a hypovascular irradiated bone. The area of the exposed necrotic bone with absent healing for 6 months, that's one of the criteria before you slap that diagnosis of ORN on that patient. And we can see the evidence of the mucosal necrosis as we showed you some examples, and it ultimately gets into the bone and then can cause the osteoradionecrosis. These are all the risk factors for development of ORN. This is how it looks. Macroscopically, very ulcerated, devitalized, hypovascular bone. Looks like it's like a pus-filled cavity. So what are the 3 H's that lead to development of osteoradionecrosis? So you have hypovascularity to the area. We know radiation can do that, which will lead to hypoxia. Hypoxia can lead to hypercellularity, and then finally, which can lead to tissue breakdown and a non-healing wound, which ultimately ulcerates and involves the bone. And this is just another macroscopic image of that. Usually in the head and neck, you will see ORN develop in the mandible, and it's the body of the mandible that is more susceptible to ORN compared to the parasymphyseal or the angle region of the mandible. Patient with nasopharyngeal cancer who was radiated, and you can see some osteitis early on, and then you can see this patient at 2 years later now, you can see the heterogeneity. There are areas of dense bone, areas of loosened bones, And then when they had gone in, they saw a big mucosal ulcer, and this was osteonative necrosis of the skull base in this patient, unfortunately. This is a 40-year-old, 9 years ago was treated with radiation, and again on MRI you can see again a non-enhancing big blob of soft tissue sitting in the central skull base. Get the corresponding CT, again you see areas of dense, areas of lucency within that blob, and later on you could see this area of like a rim of air around that blob of soft tissue. This was biopsy, nothing radiation necrosis ORN.
Sorry, Dr. Majid, we have 2 minutes left.
2 minutes, okay, thank you. Carotid blowout, as you know, vascular issues can happen with this, and you can see here that the lumen of the carotid is completely gone, and that's one of the vasculopathy complications that you see with radiation therapy. Pseudoaneurysms can be induced here, nasopharyngeal carcinoma, treated, development of this big heterogeneous T1 and T2 area right in the paracellar region, and angio was done, and this was a big, huge ICA aneurysm in the patient post-radiation. Quickly going over the radiation-induced neoplasm, they can happen anywhere from 4 to 30 years after the radiation therapy. Meningiomas, sarcomas, schwannomas are typically seen in these patients. Here is a patient who had radiation, and of course this is a big osteosarcoma that is developing off of the mandible. This was a patient of NPC that was treated, and you can see this heterogeneous mass that is developing in the central skull base, extending along the sphenoid wing, and this was another radiation-induced osteosarcoma that had developed in this patient. So what do we need to make this diagnosis? That the histology has to be different from the histology that was treated. The secondary neoplasm has to arise within the radiation planned area. Latency period has to be more than 5 years. And of course, all of these secondary malignancy have to be histologically proven also. So those are the 4 criteria that are needed before you can slap that diagnosis on the patient. Cerebral radiation necrosis, we already saw, okay, so I'm not going to spend a lot of time. This is vascular injury, oligodendrocyte, as well as white matter damage, and immune mechanisms that come into play with development of this. Again, it's very important to know that where the radiation zone was, what part of the brain was included in the radiation. It used to happen much more back in the day when conventional radiation was given with involvement of the temporal lobes, and then you would develop something like this. So when you see something bilaterally in a patient that had been radiated in the central skull base with conventional radiotherapy, that is development of cerebral radionecrosis. So in summary, look at your study indication, routine follow-up versus new symptom, review the clinical exam, look at the pathology, and always compare to multiple priors will be very, very helpful. Spend extra time reviewing a post-treatment scan as you would for a routine neck scan. And if you are in any doubt about an area that you cannot clear on a present scan, tell them to go back in there again, look at that area, or if you're looking at a CT, get an MRI. If you're looking at an MRI, get a CT or a PET scan to further clarify it rather than letting it slide, because your doubt may be something that you are on to early on in imaging and can be very beneficial for the patient. So don't let that go. Thank you.
Thanks, Dr. Majid. We will continue with Dr. Majid with the second part of his talk with a presentation about imaging of the skull base.
Okay, changing gears now, but staying in the same area. It is the central skull base imaging now. My disclosures, again, we'll go over the anatomy, we'll go over the normal vascular variants that you see in this part. We'll discuss the neoplastic processes and some dysplastic lesions that can develop in this area of the neck. So this is a patient with multiple cranial nerve palsies. CT head was done, was read as normal. Soft tissue density in the sphenoid sinus, could be fungal involvement and blah, 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 was read as normal. So Same patient, because of the indication, we got an MRI, and now you can see this big retroclival mass that is involvement of the cavernous sinus bilaterally. This was TB of the central skull base. So again, as with NPC, MR is the imaging modality of choice if you are wanting to do evaluation of the central skull base, and your routine MR will not work. You have to get this special protocol in which you do thin section imaging, cis imaging pre and post, or 3D imaging, and with FAT-SAT on post-contrast images is essential for evaluation of this. So when we look at our skull base, we have the anterior skull base, we have the central skull base, and we have the posterior skull base. So we are going to focus just on the central skull base, in which all these different areas or lesions can develop from all the different anatomical areas that are in there. So this is just the main constituent of the central skull base is your sphenoid bone, right? So this is your basisphenoid. This is your greater sphenoid wing. You don't get to look at the lesser sphenoid wing on an axial image such as this. But when you do a coronal image like here, you have, it's not an image, I know this is, when you put it coronally, you will see the greater wing, and then you see a lesser wing. And if you look at this picture, this reminds you of like a bat or a bird's wing. And that's exactly what it is. So this is the greater sphenoid wing, and this is the lesser sphenoid wing, and this looks like a bird. Here you can see very nicely that it is like almost bat shape in this skeleton. We can do the 3D volumetric reconstructions, and we can see the clinoid processes, greater wing of the sphenoid, the foramina of the skull base very nicely. So that's the sphenoid bone. That's easy to see. What other bone is involved in the central skull base, which is the palatine bone. And you can see that it's almost like an L-shaped bone. This has a perpendicular plate and a horizontal or a posterior plate, and then it has a process posteriorly also. So if you look at your axial image, this is your palatine bone right here. And if you do MPR oblique reconstruction, you can see the palatine bone here. So this is the posterior process, and this is the perpendicular plate. And behind that, you can see your pterygopalatine fossa. So that's the second bone that is involved in the central skull base. And of course, when we talk about the pterygopalatine fossa, we have already drilled down on this
Dr. Majid,
sphenopalatine ganglion.
excuse me, the pointer is not working.
Oh, it's not coming on here? Okay, sorry. So here, this is where the palatine bone is, and this is the reconstructed image we said about the sphenopalatine ganglion and all the connections that the sphenopalatine ganglion has. We've already talked about it in great detail. And this is your PPF, sphenopalatine foramen, pterygomaxillary fissure. Rick just talked about all of that in great detail in the previous talk. So let's go over the axial and coronal anatomy. So here we have the clinoid processes, and as we are coming down, this is the optic strut. So this would be your optic canal. We are coming into the superior orbital fissure there. We are going down from there, and then at the level we have the foramen rotundum that you can see on here, and just inferior to the foramen rotundum you have the Vidian canal that is leading down into the wall-less foramen with no boundaries. That is the foramen lacerum, and then of course from foramen lacerum you extend out laterally into foramen ovale and spinosum. And that's ovale and spinosum, and of course we already said that, a lady with the high heels, and the footprint is exactly the same like that. And on the coronal image, that's your foramen ovale. So clinoid processes, optic canal, struts, the Vidian, the rotundum. You can see that on MRI also. You have on pre-contrast T1 image, you will have the bone that will have some fat signal in it, and then as you scroll down, you will see the rest of the anatomy. The second other important thing that you have in the central skull base is your sella turcica, having the pituitary gland inside of it. And then as you extend out, you get into the Meckel's cave, and then you extend out and you get again into the foramen ovale. Cavernous sinus is part of the central skull base, so pathologies that will involve the cavernous sinus are pathologies of the central skull base. We already talked how the nerves are in there, arranged on the lateral wall, and 6, which is right next to the carotid artery. Okay, so let's move on a little bit to the embryology of the vertebral column. So this is your notochord. And you can see that the notochord makes a sigmoid turn right here at the level of the nasopharynx. Then it comes posteriorly and touches the posterior border of the clivus and then descends down all the way down to the sacrum. And that's very important, as I will show you later on in the pathologies that develop because of that sigmoid curve of the notochord. So what are the no-touch-me lesions of the central skull base? Obviously, everyone knows this. This is the spheno-occipital synchondrosis. It can be present in life up to early 20s, sometimes even in later 20s. So do not call this as a non-displaced fracture when you just have a line going across, which is still that synchondrosis. There's a little divot in the anterior wall of the clivus right there, which is a linear line then extending posteriorly. So this is the canalis basialis medianus. That can be a remnant of the notochord, but others think that this is a channel for the basilar plexus. When you have a more cystic appearing lesion within the clivus per se, you start to think about fossa navicularis magna. And when you get CT on these patients, which you should get, is that you will start to see that there is a defect on the anterior wall, and most of it is sclerosis around it. So that's a typical appearance, typical location for fossa navicularis. All of you likely know this, little small T2 hyperintensity in the prepontine cistern sitting right next to the basilar artery. That is your ecordosis physallophora. Now, is this ecordosis, and can you leave it at that, or can this be an intradural chordoma? So that's very important. You can't just let it go. So we usually follow it up at least for a few years to see if there is any change in size of it. If it doesn't change, we let it go. If there's any change in size, even by a few millimeters, you know that this could be a chordoma. This patient came in for pre-op imaging for a cleft palate, and now you can see that this is the pituitary gland. There's a defect in the floor of the pituitary gland, and then something extending all the way down to the nasopharynx. And then on the axial image, you can see this big, huge canal with sclerotic edges that is doing there. And once you give contrast, you see the pituitary gland is kind of herniating down into the canal. So this is a patent craniopharyngeal canal, which contains the adenohypophysis. So they can be of 3 types: incidental type 1, type 2 is what you're looking at, and type 3 can be even bigger and can actually have brain herniating and even tumors that herniate through it. Okay, what about this? A small lesion involving the central skull base on the soft tissue windows looks like it has fat within it. So this is a characteristic lesion that you see on CT, and if you do MRI, this is pre-contrast T1, this is fat sat, and this is post-contrast with fat saturation. No enhancement there. Fat has saturated out. And this is another lesion, exactly the same signal intensity, T1 brightness on MRI. So these are all examples of arrested pneumatization, or what we now call as variation in marrow pattern. So be very careful about these lesions. Do not let them biopsy this lesion, or do not yourself biopsy these lesions, because these are no-touch-me lesions. So they're very common. You will see non-expansile sclerotic margins. They will have little or no enhancement. You should not have robust enhancement. If you have robust enhancement, then it cannot be a variation in the marrow pattern, and they are usually small adjoining the sphenoid sinus. What about this one now? This is a patient with nasal stuffiness. It does have those sclerotic borders. It does have that break in the anterior cortex like I showed you for fossa navicularis magna. Can this be the world's largest fossa navicularis magna? But we are very high up here. As I said, remember that curve that I showed you? The curve comes more posterior, so usually the fossa navicularis magna is right here, so it's likely not going to be that. But still, on CT, you're not going to answer this question, so we went to MRI. Now you see precon T1, it's dark, there's no fat in it, that's your first clue. Then the second clue, it is enhancing homogeneously. So this is not variation in the marrow pattern. You absolutely cannot call it that. And this was surgically proven ectopic pituitary adenoma in this patient. What about this one here? So we have sphenoid sinus. We have some soft tissue density within the sphenoid sinus. It is dark. It has a little bit of soft tissue prominence, a little bit of high density within it. Can it be fungal hyphae, fungal ball, or whatever? Absolutely can be. But looking at the brain here, what's happening here in the brain? We have a fissure that is widened in the temporal lobe right next to it. Something to look at. So you go to an MRI and you see this is all fluid. Again, you see this widening of that fissure. You get your coronal image and you have this big, huge encephalocele that has gone through into the sphenoid sinus. So be very careful when you are calling just these mucoceles or a little bit of fungal hyphae and all that in your sphenoid sinuses. What about this one? T2, heterogeneous appearance, definitely T2 bright. Pre-contrast T1, it's dark. My pituitary is well and good, so nothing wrong with the pituitary gland, so I'm okay with that. But something is going on in the sphenoid sinus. I give contrast. Pituitary is clear, so nothing wrong with that, but something. Can this be tumor or a sinonasal tumor? Absolutely could be. So really, it's very hard for me to say it has to be a differential for this case. Get a CT, fibrous dysplasia. That can always fool you on MRI depending upon what stage that fibrous dysplasia is in. So this was in a mixed phase. It had some lytic component also. This was another case. Again, fooled us on MRI because we were thinking about our differential. This was discussed in our interesting case conferences, and we were butting our heads what this could be. Finally got a CT and was fibrous dysplasia, straightforward diagnosis. Very nicely MR complemented by CT in this case. Okay, now move on to the pathologies that we see and the imaging characteristics that can help us differentiate those pathologies. I'm going to go real fast. This is, everybody knows about it. When on a T2 weighted image, you have something within the sinus that is as dark as air, you know this is going to be fungus. And fungus can be bright on T1, on CT. You just have to look for any dehiscence of the bony wall, invasive fungal sinusitis versus allergic fungal sinusitis. So that's the distinction that needs to be made when this happens. So here is another example. Now here you have osseous destruction. You have some more tissue within that orbital apex on that side, immunocompromised patient. So all are red flags in this patient. You do an MRI, there's enhancement there. There is intraorbital extension there, orbital apex, cavernous sinus, gone. So this was invasive fungal sinusitis that was happening in this patient. Typical diagnosis, pituitary macroadenoma with suprasellar, parasellar extension, very easy diagnosis, but that comes in the realm of the central skull-based pathologies. So here you can see pituitary adenoma that has more infracellular component, and that's growing into the sphenoid sinus, as well as paracellular extension, completely encircling the carotid, but you can still see the maintained lumen of the carotid artery, which is typical for a pituitary macroadenoma. And you have this median, the medial, and the lateral wall. Only if you have it going to the lateral wall and across it is complete infiltration. But the only caveat and the only thing that is, if you have involvement of the inferior sulcus, that is infiltration of the gland. You do not have to see it cross all over. I can have tumor come up to here. That is infiltration of the cavernous sinus. So these are different phases of pituitary adenoma. I'm sure all of you have seen. They can be humongous in size. They can completely fill up the middle cranial fossa. But you look at that carotid, even when they are so big, they do not constrict the lumen of the carotid artery, as opposed to the other diagnosis that we see, which is the meningioma. So these are all different phases of pituitary macroadenoma. Okay, so on this non-con scan, looks like a pituitary macroadenoma. It's in continuity with the pituitary gland. You give contrast, and I see differential enhancement. So this is my normal pituitary gland that is enhancing very normally, as it should, very similar to the adjoining cavernous sinus, but this is differential enhancement along the superior aspect. Do a coronal image, and it's a little sliver of tissue is extending along the anterior skull base. So this is a meningioma that is arising from the diaphragma sella on top of the pituitary gland. So that's another diagnosis that you will see very commonly in this region, and these are, again, this is a plenum sphenoidale meningioma. Again, it's coming down all the way to the cavernous sinus, the pituitary gland, and you can see that dural tail sometimes. You don't have to see the dural tail. This is a very characteristic location for this. Cavernous sinus has been completely infiltrated, and now you can see how the life of that carotid artery has been squeezed out, because it's a pinpoint now compared to the normal carotid artery on the other side, even though the size of this meningioma is very, very small. And that's one of the typical feature of cavernous sinus. When the meningioma gets into the cavernous sinus, or the spheno-cavernous meningioma, what we typically call it as, will squeeze the life of that carotid artery. This is a typical example. Very, very bad meningiomas to treat, the spheno-cavernous meningiomas. You can take care of the sphenoid wing part, but they can't really scrape it off from the cavernous sinus, and they leave it there, and then the patient has to undergo follow-up imaging for years and years and years just to see if it's growing or not. This was a very unusual case, 2-year-old with cranial nerve palsy. And when we image this, this is what we see, 2-year-old. You don't think about meningiomas, so we were thinking about maybe this kid has some sarcoma. Can this be just a schwannoma of the fifth nerve that is coming out of there? But when they went in, to our surprise, this was just a plain and simple clear cell meningioma, even WHO grade 2. This is another of similar lesions, spheno-cavernous lesion, which is extending, destroying the bone, and it's extending into the sphenoid sinus. Can this be meningioma? Unlikely. This is meningioma because, remember, meningioma-induced osteoblastic bone changes. Typically, atypical meningiomas will not, solitary fibrous tumors will not, but typically what we associate with meningiomas is osteoblastic reaction in the bone. It's enhancing, not homogeneously, peripherally enhancing there, but it's kind of sort of dark on T2 weighted image. So that's different from what we are usually used to, heterogeneous here. So that's different from what we see for meningioma, and this actually turned out to be a plasmacytoma. This is another interesting case that we had, that hypothyroidism and some visual dysfunction that this young patient had. So you can see that it's really bright on T2 weighted image. Diffusion, it did not have any diffusion activity. And you can see the evident enhancement. This is almost arterial enhancement that you're seeing on there. So we were thinking about, okay, this could be slow flow venous lymphatic malformation that is involving the central skull base and the pituitary gland. So we said, let's take the patient straight. They took the patient straight to an angiogram, and this is the angiogram that was done, which was not really revealing much. Yes, there is a blush, but you thought that it would be more blush because they are very deep into the venous phase here, so the blush should have been more. So we said, okay, let's get the patient back and let's do a dynamic imaging of the pituitary gland. So this is the non-contrast image. This is the early arterial phase and little later phase and little later phase. So we proved on this dynamic imaging that this is actually a slow flow venous malformation. They went in and took it out, and it was a slow flow venous malformation. In kids and old people in about 6th or 7th decade of life, you will see this diagnosis in which you will have a cystic component, you will have an enhancing soft tissue component, and you will have a calcific component. When you have all these three components in a mass that is in the suprasellar region, your diagnosis is a craniopharyngioma. There are many phases of craniopharyngioma. You can have adamantinomatous craniopharyngioma, which has all the three components that I just showed, but you can have a papillary craniopharyngioma, which is completely solid with no calcific or no soft tissue component, which is more commonly seen in the older age group in the later half of life as compared to the early 5 to 15 age group. So it's a remnant of the Rathke cleft pouch. Okay, so what do you think this is? Craniopharyngioma. This is a pre-contrast T1 weighted image, and you have a lesion that is very bright on pre-contrast T1. This is T2 weighted image. This is bright on T2 weighted image as well. And this is your post-contrast image, and pretty much there is no enhancement on this because this was really, really bright on the pre-image. So anyone thinking that this is a craniopharyngioma? Good, absolutely. And the clue here is this guy right here, okay? So that's very helpful. There was a very beautiful paper in AJNR 5 or 6 years ago that had come out, and the only clue, a definite clue to a Rathke's cleft cyst is presence of this intracystic mural nodule. And once you have that, that's your diagnosis. All other findings like fluid level, peripheral hypointense rim, internal septations, and off midline location are all cystic adenomas. And this is the only thing that you can just say it and you're done with this. Okay, this is a patient with galactorrhea and moderate elevation of prolactin. So you see this on CT was done at an outside hospital for this patient. They thought this is a macroadenoma of the pituitary gland, though most of the macroadenomas of the pituitary gland are of null cell type. They're not hormonally active. They cause more problem because of their mass effect. But patient had some elevated prolactin levels, so they thought that this is adenoma, and they started treatment on this patient, and they started the patient on bromocriptine. Patient continued to have symptoms despite being on bromocriptine for 6 months, and was sent to Hopkins, where we started out with an MRI with that history that we had, and we see this. So please be sure that you never let your surgeon touch something like this. Whenever you see dark signal on a T1 weighted image, obviously this is a little heterogeneous. You see some soft tissue iso-intense signal also, but there is dark signal around it. On a T1 weighted image, that can be air, that can be dense bone, or that can be high velocity blood. So that's exactly what it turned out to be, a big, huge aneurysm that was coming off of the ICA, and so the patient got that treated and was happy. So the moderate prolactin elevation was probably from the stock compression effect. This case I already showed. This is a post-radiation induced aneurysm in my NPC treatment talk, and you can see the heterogeneous appearance. This one is very confusing actually, because you wouldn't really think about if you're not thinking about an aneurysm. And we saw this, and we saw this flow void, and that made us think, could this be an aneurysm? Patient has had radiation for this, and obviously this turned out to be a big, huge pseudoaneurysm that was arising from ICA. Okay, moving on. When I put this history up, the diagnosis should be straightforward. So 16-year-old boy, headache and epistaxis, avidly enhancing mass involving the central skull base. Angio was done. Yes, 100%. So it's a benign, highly vascular mass that arises from the sphenopalatine foramen, PPF, and very important that it's a diagnosis of male. If I had that 16-year-old female, you would probably not think of this diagnosis, but male sex is very important for this diagnosis. And this is just another example. About 15% of this nasopharyngeal angiofibromas can be completely within the nasal cavity, so you don't have to see them outside in the PPF, so they can be inside the nasal cavity also. So be aware of that fact that it still can be a nasopharyngeal, juvenile nasopharyngeal angiofibroma. 17-year-old boy, right-sided facial numbness, big, huge mass that is tracking along that fifth nerve. This patient, unfortunately, turned out didn't have the diagnosis. Bilateral involvement of masses in the IACs turned out to be NF2 diagnosis after this scan when they worked this patient up, obviously because of this bilateral IAC masses. Okay, now, another diagnosis, central skull base, lytic mass involving the central skull base. Like this, absolutely. You see hyperintense T2 signal, very important. Very, very important that when you have mass anywhere in the spine, not only the skull base or the sacrococcygeal region, about 18% of chordoma can happen anywhere up and down the spine. So it's very important to see the signal characteristics of this mass. Anytime a mass has signal characteristics that is approaching that of CSF, think about chordoma. And it can heterogeneously enhance also. So this is typical notochordal remnant tumor, very bad cancer, and can present, in this location, can present with multiple cranial nerve palsies. Again, the key feature is T2 hyperintense signal. We do a lot of diffusion-weighted and perfusion-weighting imaging on chordomas. Hopkins is a chordoma hub, and we get to see a lot of chordomas. So we're doing a lot of diffusion imaging and ADC. This is one of the tumors that has perhaps been most studied on ADC mapped images because our numbers for bone tumors are not as robust as we know in the brain. So we are still looking at this. But if I see a bone tumor that's bright on T2 that has ADC value anywhere over between like 1200 to 1600, I'm thinking of chordoma.
Sorry, Dr. Majid, we have 2 minutes.
Okay, so here, but you can see variable varieties of chordoma. I thought this was 30-minute talk. Still 30? Oh, wow. Okay, so dedifferentiated chordomas can be completely dark. So I'm going to go a little fast here. So this is biopsy-proven chordoma. Again here, and this is the reason that notochordal sigmoid turn, you can see that this chordoma was more in the nasopharynx rather than in the clivus. That's because the notochordal takes that turn up in the skull base. This is a very good tumor that we had. So what happened, we were thinking about chordoma, till we did the CT. Chordomas are lytic on CT. If you see sclerosis on CT, highly unlikely to be chordoma. So the cousin of chordoma is a giant benign notochordal rest, and that's what it turns out. Pathologists will not be able to tell you that. They will see brachyury positive for this diagnosis. You are the ones that are going to make this diagnosis, because pathology, you send this slide to pathology, they will say brachyury positive chordoma. But sclerosis is very important. That differentiates chordoma from a benign notochordal rest. Okay, petroclival groove, masses that arise from the petroclival groove, they are also T2 hyperintense chondrosarcomas. They also will have some calcifications associated with it, so that's very important to see these calcifications, which our MSK colleagues say, like comma-shaped calcifications. I never really get to see that. But T2 hyperintense bright, on chondrosarcomas, your ADC value has to be more than 2,000. Once I see that, I'm very confident in calling something as a chondrosarc with ADC value of more than 2,000. Nasopharyngeal carcinoma, we already beat it to death. We have seen many examples of that. And finally, you can see this perineural spread skin cancer that is getting into the masticator case, getting into the foramen ovale, getting into the cavernous sinus, getting into the root zone of that fifth cranial nerve, and you can see that that is spread all the way down into the pons where the nucleus of the nerve is. So that is, perineural extension is quite common to be seen in this area. And this is, again, a big, huge nasopharyngeal carcinoma that is involving all the vital structures around it in the central skull base. Okay, so sphenoid bone is the main osseous component of the central skull base. You can have benign variants. Be careful when you are reading those, and because they are no-touch-me lesions, don't biopsy them, don't send your surgeons in to take care of those lesions. CT and MRI, as with most other areas in the head and neck skull base, they really complement each other very nicely, and I showed you a few examples of that. And lesions that are centered in the skull base can extend to the adjacent intracranial and extracranial compartments also. Thank you very much.